Today we're going to learn about the TMJ. Hopefully you're able to look at Taylor's slides. They had a lot of great information. My slides are much more simple. They do not have as much information, especially on the anatomy and physiology. So please refer to hers as kind of as like a reference text, and if you really want to learn more about it because you're interested in treating it. Moving forward with my slides here, I'll go over the things that are different from hers and kind of really bring in the clinical implications for TMJ practice from my years of treating it. First off, if you are curious about some of the biomechanics of the TMJ, the temporomandibular joint is what that is. It's not the dysfunction. That would be TMJD. But if you want to learn just kind of normally how it is, there's the video down here of the 3D model, how all the muscles work. There's also the one above that shows how the disc works and the dysfunction. It's very hard to explain that. I'm going to try to do my best with the pictures, but if you'll just watch that video, then it does it perfectly, and then it shows what the dysfunction looks like. So please refer to that. We have a lot of this good anatomy on the other set of slides. Just wanted to point out here on the disc, it was mentioned before on the other slides about how it's this dense fibrous tissue as opposed to the hyaline cartilage. And that's important. It might be a slightly inferior or lower quality, if that is such a thing, of material. It's a different type of collagen. But the advantage to that is, since we're all talking and eating and using our mouth all of our lives, is this is the one type of tissue that can actually remodel. So that's, and I guess it was right here, that lifelong usage and healing can happen because of that type of fibrous tissue that it has. As such, when we get to our treatments, we'll talk about certain remodeling techniques that can happen. So to the disc here, the disc is also a dense fibrous tissue, and that disc has then this retrodiscal tissue behind here that helps pull the disc posterior, or at least keep it attached posteriorly so it's not sliding anterior and getting stuck in front of the mandible. Again, refer to much more detailed information on Taylor's slides. When it comes to the normal opening, we're looking for about 3.5 to 4.5 centimeters. That's about 2 fingers widths, depending on the width of your fingers. That's that functional opening. When we're talking, when we're doing normal eating, with a fork and you're not taking huge bites, that's that range that we're in. With the mandibular depression, that's the full opening, then yes, that's going to be more in that 4 to 6 centimeter range. That's that full 3-finger width at that point. When we start getting into 4 fingers, that's usually going beyond that 6 centimeters. That's when we're looking at hypermobility, and we'll have some tests and techniques on that later. For the opening mechanics, basically that first 20 to 25 millimeters is all done from rotation. So it's kind of hard to demonstrate, other than with my Pac-Man hands, that pure rotation, that opening motion like an alligator. That's what we're doing for most of the time when we're not taking large bites, when we're not opening our mouth a ton, when we're not talking like this, but kind of mumbling along. That's what that rotation is. If we are doing a larger motion, the rotation is still, basically the rotation is still happening because that first 20 to 25 is from that rotation of the condyle. To me, it kind of reminds me of the glenohumeral joint, how that first part of the motion is the glenohumeral joint moving right as you elevate your arm, and then at a certain point, 60 degrees if I remember right, it's the scapula that then gets involved. So that's kind of what we have here. That rotation piece is like the rotation, or in this case the scaption, that's happening at the glenohumeral joint. Then we have the next piece, which is the translation. The translation is then like that scapula sliding to the side that then creates that much larger motion that gives us 180 degrees. So same thing here, there's just that Pac-Man opening for the rotation piece. Then once you pass that 20 to 25 millimeters, then you get that translation. It's that jaw jutting motion. So again, 20 to 25, and then to increase that further, then the jaw starts to anterior translate while it continues to rotate. And that's when you get those larger openings happening. As with always, please, as you're listening to this, looking across all the slides, note any questions you have. That's what our piece is for on Friday. I think it's at 11 o'clock that we're coming together to debrief TMJ. Any questions you come up with, please note those so we have some talking points. Closing then is pretty much the opposite. I did forget to mention this because this part is talking about the disc. The disc is kind of on top, as we see here. It's on top and slightly posterior to the retrodiscal tissue, or to the mandible, where the mandible attaches. And then as you open up the mouth, then the disc actually slides. It comes forward. So basically the way you describe that is it's just kind of hanging out here with that mandible, but as that mandible opens further, it would be sliding off that disc. So the disc actually comes with it. And then at a certain point, then as you're starting to close, then that retrodiscal tissue pulls it back with it. So essentially that disc becomes that cushion. It would be kind of like the cartilage moving with the jaw. But in this case, I mean, we think of the glenohumeral joint, that kind of ball and socket. The scapula, or the glenoid, can move with the humerus. And that's normal for raising your arms. But with your jaw, that would be very difficult if every time you wanted to open your mouth, your head was having to move all around to create that larger opening. So in this case, the disc just moves with it, and it's helping cushion that joint. So then the opposite happens here. This just then ties in when those movements are happening, some of the muscles that are involved. Big thing to think about where things are moving. Everyone walks around saying, hey, I have TMJ. It's like, yes, we have two TMJs to be precise. The better terminology would be TMD, that temporomandibular dysfunction, or TMJD if you need to. That would be the TMJ, or the TM joint, temporomandibular joint dysfunction. But what we're actually finding is it's almost impossible to have TMJ dysfunction and not be related to our posture. Of course, as we often talk about, we talked all through the cervical spine unit about how big of an influence posture is, and how maybe people didn't have these issues 30, 40, 50 years ago before the prevalence of electronics with phones and computers and desk jobs and all of that. Well, now so many of us do have that forward head posture, and then that directly affects the mechanics of the TMJ. So nowadays, really the much more appropriate terminology if somebody has pain in their TM joint would be actually craniomandibular disorder, because in that case it's coming from the posture. That's like the root cause, where this is more of the symptom. But you could still have TMD within an overall CMD, the craniomandibular disorder. Sorry. Next, we do have the different types of TMD or CMD that will kind of help break down for you. That's a little bit different than we saw on the other slides. First, we have this disc dysfunction, and it actually has reduction. The following type is then without reduction. So with reduction, what that means is there's disc dysfunction, which is blocking the movement. But as it reduces or gets to the other side or out of that restriction, you then have normal opening. So that's why there's that disc dysfunction early on, but then it reduces and it becomes normal movement. So with this one, as you kind of see in the picture here, as you are opening up your jaw, the disc is placed too far anterior. And that's happened because this retrodiscal tissue has been stretched out. So it stretches out and even can slightly tear or it loses that elasticity. So then that disc just hangs out anteriorly already. So then as somebody opens up their mouth, it's a little bit limited, and then finally it clicks and goes to the other side of that disc, and then the jaw can open normally. And that's kind of what we're reading through here. So as that person's opening up their mouth, it's usually only locked on the one side. So they'll get that deviation, we call it a C line or C deviation, and that's where they're opening to the one side. But then, because it's locked over here, this side's opening just fine and moving. So and it's kind of hard to imagine here, but again, it's almost like we have these two joints. So if this joint's not opening, but this one is, that would make sense why it would cause that deviation to the side with the disc dysfunction. But once this finally clicks and gets over the disc, then it comes back to midline, and then that normal opening can happen. So it would be called the C line if they just went over and stayed there, and that's actually the next slide. But then if they're able to get over that tissue and that click happens, then they come back. So that's where it traces more of like an S is what we call that. And then as they close, they then have to click back over that disc, and then it finally gets locked anteriorly again. So that's how you know it's a disc dysfunction. It's more of a click as opposed to a clunk or really loud pop, and it clicks both with opening and with closing, and then you notice that kind of S line. I will just kind of throw in a spoiler alert. Even though many of us might have TMJ tightness or pain at times, many of us do not have major disc issues. So you may be trying to open up your mouth and, oh, I think I have this, or I think mine's locked, or it's not reducing. And you're probably not right with that. It really does require an objective observation of watching those motions and measuring the distance. You might have an S line, or you might only have a C line, but you're opening to 60 millimeters. That would not be a locked disc. A locked disc can't open their mouth beyond even 20 millimeters, or maybe 25 or 30. So referring then to the next one, we have our disc dysfunction without reduction. So again, here's the disc. This jaw is opening up. I guess you can't really correspond the two of these. So I'll just point here with my mouse. So this is the anterior side. So that's where that jaw is opening. Well, as it opens, it tries to push into that disc, and it's not letting it happen. So then it just keeps trying to open, and it just keeps kind of mashing up that disc until finally it can't go any further. Like I said, maybe only 3 centimeters. So then it just has to close. So there's no pop or click or whatever, because that retro disc just stays there and it blocks that opening instead of it popping through, and then the jaw can open like normal. So that one is that C-shaped motion, because this side just stays locked while this side's opening normal. So then it just goes to that side and stays there. In terms of treatment, we'll get into some of the more specific things, but just like we've seen with all of our joints, is this a hypomobility issue, a hypermobility issue, or something else? In this case, it is that hypomobility. It's restricted. Even if it's just restricted but still reducing, it's still kind of limited and things are tight, and that's what's causing some of that dysfunction. So as such, just as we do with our other joints, we need to mobilize the soft tissues, we need to mobilize the joints, and we need to be stretching and loosening things up. We'll show you the mobilizations in a few slides here. The stretching just gets noted here. I don't think it's really later on. We can pin and stretch the temporalis. Think of that temporalis muscle going above the ears. You can actually put your fingers through your hair there and press in to that temporalis, and then you can open up your mouth, and that's now stretching that other side. And you could run through 5 to 10 repetitions of that. Another thing when it's this hypomobility, sometimes it's that prolonged low load stretch or low load prolonged stretch that really allows us to stretch collagen, stretch scar tissue, stretch limiting passive structures. Well, it's kind of hard to hold your mouth open for 3 minutes, especially if you have a lot of tenderness. So when you use the tongue depressors, they will help hold your mouth open for you so you can essentially rest the muscles and not try to force it open. And that'll help just slowly stretch that. I found with my patients, if I just allow them to bite a little bit, to do a contract relax, they can bite, not to the point of causing it to spasm, but they're biting that. And plus their mouth is a little more open. So they bite through that, the tongue depressors, to apply a little bit of pressure just to engage those masseters and other closing muscles, and then they relax. And as they relax, they notice they can usually stretch out that jaw more. And then again, if they want to hold that position, then they can use the tongue depressors. It also gives them a great way to measure where they are in their progress, where maybe they were 15 tongue depressors and now they're at 16 or 17 a few days later. Some of the soft tissue work we'll go over as well. The opposite then would be the hypermobility. In this case, somebody can open up their jaw well beyond 4 fingers, and as they do that, there's a clunking that happens, almost like you call it like being double jointed with other joints and things. And that's because the eminence right here, when they open up their jaw, that the piece of the mandible goes across that articular eminence, and it's much more like a clunking that happens as opposed to a clicking, a grinding, a little popping. That's much more like a disc dysfunction. The other thing again is that the point of when the clunk happens. If it's happening at 55, 60 millimeters, their mouth is very open. That's a clunking of that condyle over that eminence. If it's happening where there's a popping and I don't know, maybe it's a clunk or whatever, and it's only 20 or 30 millimeters, then that sounds much more like a disc issue. And then you add in any of those S lines or C lines to help confirm some of that. Basically, what's going to happen here is it'll deviate away from the hypermobile side. So it's still the same as disc, because with the disc, it's the hypo side that it's going towards. With the hypermobile one, it's still going to go towards the hypo side. But in the case of the disc, the normal side is the hyper side. And in the case of the hypermobility, that's the dysfunctional side. So now the normal side is the hypo side. So in this case, if I have dysfunction where I'm hypermobile only on my left side for some reason, if I open up my mouth, it'll be straight and normal, and then at the end, the clunk will happen on the one side, and then it will deviate over to the normal side. If you're just generally hypermobile and there's no real specific dysfunction there, then as you open up, you'll get the clunk all at once on both sides, and then that'll just create excessive opening beyond that 60 millimeters. Basically, these patients, it's going to be much more like an overuse issue. They've had this hypermobility forever. It allows them to eat a really large, tall hamburger or whatever, but if they're constantly exploiting that, then that extra wearing is what's causing inflammation and then problems from there. So naturally then, that kind of patient is going to get some stability. We're going to teach them where they hold their tongue. I'll show you right now. We're going to teach them to not open their mouth so wide with certain things, and have smaller hamburgers or split it in half or whatever. We're going to be palpating right here, just in front of the ear. Everyone can try this. You open your mouth and feel that mandible moving. Many of you will be able to open to such a point at the end of the movement, you'll feel it pop out and really move forward. That the condyle of the mandible slipping down and forward. In terms of treatment, we're going to teach them jaw isometrics. That's the picture down here. I'm going to resist lateral deviation. I'm going to resist opening and closing. I'm addressing any muscle weakness or possible dysfunction of those, especially if this person's had hypermobility and now it's turned to inflammation, and then the muscles are now restricting and spasming and guarding. You may have to do soft tissue work to calm all of that down. In terms of that tongue position, that's this picture right here. We all have our lip, and then it's the teeth, and then there's that hard palate. There's that ridge right here, the hard palate, and then it's the soft palate. And you can feel that with your tongue. The roof of your mouth feels very soft right here, and then it's much harder until you get to this ridge. The normal resting position for your tongue is on this ridge, right where my mouse is coming towards. It's not on the back of the teeth. It is not on the bottom of the mouth. It is right there up on that ridge. If it needs to be a little bit higher, it is what it is. That's better than any of the other positions, but the best position is right through here. So, I mean, I can't really hold it. So if that's the ridge, this is now the opposite direction. My tongue's coming right up to that point. Again, it's not against the teeth. It's not above the ridge, but on the harder palate. But that's technically okay. But it's just coming right up into that. So hopefully you can feel that. If you just have no clue what I'm talking about, you could also say put your tongue against your top teeth and then start pulling it up, maybe 1/8 of an inch, until you're just resting on a harder surface there. And sometimes that's all you need to do. We'll come back to the soft tissue work. Here are a couple kind of research things. Sorry, they're not linked here, but you can look these up based on the last name. But they have different ways to treat patients with essentially TMJ dysfunction. This Furdo, he gets really into the concept of the CMD that we're treating. These patients get CT mobilizations. They even get thoracic mobilizations. They get cervical mobilizations or manipulations. They get all the soft tissue work of the upper back, the neck, and the TMJ. And then they get all the specific TMJ treatments. And in doing that, they can really take care of the underlying CMD, but also the kind of symptom, the more specific TMJ dysfunction as well. But again, it all comes from posture. So just like we learned in the thoracic and cervical spine, we're soft tissuing all of those upper thoracic and cervical muscles. We're returning mobility with foam rolls, with grade 5s, with mobilizations to the thoracic spine, and then of course everything for the TMJ that we'll get to now. Some special questions to kind of add to Taylor's, many of them the same. One thing you do need to ask is the latex allergy. 99 or 100% of the time when you're in people's mouths, it should be with gloves, and most of those gloves, or at least the more affordable ones, do have latex. So that needs to be asked first before you're using them. Should be a good idea to have some non-latex gloves in the clinic. Otherwise, you'd have to order them or pick them up quickly before the patient's next appointment. I'm doing observation using different measuring devices. Sometimes I'm stuck using my large goni, which isn't very precise, but you use what you can. Very easy. Some people just use a piece of paper and they'll mark on the paper the starting and end point, and then they can measure that later on. So, but definitely doing that observation. Fingers here, so you can kind of use your biomechanics to figure out what that mandible is doing, and then measuring all the different limitations, and things will come out, and once you add up all of your pieces, it should point towards one of those types of dysfunction. Taylor talked about resistance, so here are some versions or quick, easy ways to do that. There is a special test, actually a couple of them, that are interesting. The cotton ball test. You'll actually put a cotton ball in your teeth, and if you bite that and it doesn't bother you, then you probably don't have a disc dysfunction. Disc, it's all about the range of motion. It's the movement of your jaw. So if you put a little space between your teeth there and you're biting on that soft cotton ball, then you're probably fine. If there's pain with that, well, that's now engaging those muscles. So if you have trigger points or knots or inflammation of those muscles, and now you bite, that could irritate those. So again, pain would be probably more of a muscular issue, no pain, but then they have pain in their TMJ the rest of the time is more indicating the disc. With auscultation, so then of course you can sit and listen to the TMJ, and if you close it, and you hear crepitus, kind of little popping, squeaking sounds, then there's probably some OA going on there. But again, the nice thing is that fibrous disc, essentially the socket part of that joint, that can all be modeled with different TMJ treatments here. In terms of joint mobility, we do this for assessment and treatment. As scared as that patient looks, that is actually what the treatment looks like. You're going to be on the opposite side that you are testing. You are holding the patient's head. It doesn't have to be quite that much of a death grip there, but definitely stabilizing around the head. You're then taking your thumb, going onto those molars. So really those last three molars, and kind of wrapping it a little bit into the front. And of course, you need a glove on. And then you're reaching back through there. Your finger then can reach around. It's very tender through here. This is where the TMJ dysfunction is. So maybe go to this angle here, or even just a little bit lower. Again, we have some muscles there. They can be tender. But if you can at least just grab, like we call them the tertiary levers, just kind of grab a little bit of leverage there. But mostly you're grabbing onto those molars, and then you can pull straight down, or you can pull down a little bit to distract, and you can push back or pull forward. That's what we're doing when we're assessing that joint mobility. And many times, especially with the hypomobile disc type patients, you can't pull down at all. So then how can they be rotating? They don't have any of that kind of downward motion happening. And lots of times they'll be limited with that anterior translation as well. One thing to note that I didn't see come up in the previous slides, it's probably something we just mentioned in the past, our patients oftentimes, they skip from rotation to lateral translation. So instead of having that nice 2.5 centimeters of elevation coming from pure rotation of the condyle, they maybe have 5 degrees, and then they go straight into anterior translation. Well, if you're constantly going into anterior translation, number one, that's causing some inflammation, but that's like only using scapular motion and having a glenohumeral restriction. It's like making frozen shoulder worse. So, a lot of the thing that we're doing here is trying to encourage that downward motion, and we're teaching them how to have rotation in terms of a treatment. Again, I didn't necessarily see it later on the slide, so I'll say it now. And that is, lots of times you'll have the patient, actually it is in the slides coming up, so I'll show that. It's part of the Roccobato exercises. So that's the mobilization, and the mobilization is just that. Think grade 3, you're going up and down for a couple of minutes, take a break because your arm gets tired, and you repeat that 2 or 3 times. If they're lacking in anterior glide, you can do the same thing with that. Also, while your hand's in the mouth, I've had some patients where they just you cannot restore that range of motion. So sometimes I'll even do a slight contract relax, and you can just put some overpressure to help get that opening. Some basic treatments to cover here. We have, let's see, and joint mobilization comes up again, and that we already talked about, besides all of the cervicothoracic mobilizations. But in terms of treatment, they want to avoid gum chewing, nail biting. They may need a night splint. I added a link here. It might be a simple one for them to try. If that's helping them for just a few dollars, number one, they could continue with that, and maybe between that and PT over a couple of months, they're better, and that's that. But if this is a lifelong condition, then it's probably worth making an appointment with their dentist and paying a couple $100s to have a nice custom one made. The soft tissue work, I'll go over right now. We talked over the range of the joint mobilization. The stretching, Yeah, sometimes it is just trying to pull down and stretch that, the contract to relax. We talked about using the tongue depressors. And then finally we have those exercises that I'll go over in a little bit. So soft tissue work, let's try this. So grabbing here, you find that angle of the jaw, you come forward. This whole region here, inch by inch and a half, is the masseter. Many of you that will feel tender. Those fibers are going in this angle. So try to do more of a not cross friction, but a perpendicular strumming to that. But once you feel that tender spot, you don't have to apply a lot of pressure. And usually I'll just use a couple of my fingers bridged together. Then you just apply some pressure for 30 seconds. You can add in a little bit of almost a pin and stretch there. A little bit of opening to help stretch that out. So masseter is very important. You also want to check and work through the temporalis. And we talked about like a home technique for that. And you can assign this for home as well. From there, you come to the angle of the jaw. If you slide forward about an inch, much easier on another person. In this case, I'll use my thumbs. Then you might feel little stringy fibers in there. And that's where one of the pterygoids is coming through and attaching. The other place to access the pterygoids would be sliding along your teeth. You go all the way back until you hit a hard surface. And that is where that mandible is coming up, because it kind of comes forward with the teeth and then it goes up behind. So if you'll follow your teeth all the way back till you hit that hard surface and then come slightly to the inside of that, that's where you're going to have a little bit of soft tissue there, and it's going to be very painful, making your eyes water if you have dysfunction of that pterygoid. Otherwise, if there's no tenderness there, there's really no need to work on it. From there, there's digastric muscles and some of that in the front. Again, more kind of looking for tenderness with that. And then, of course, all of the work to the muscles through the cervical spine that we've already been over. So those are kind of the major ones. It's mobilizing the jaw, masseter, pterygoids are inside, the little bit of the tendon that pops through on the underside here. And then it's just doing all these other exercises. Oh, sorry, I guess I did have a slide for that. So there you can see, just try to palpate the digastric as best as you can. There's that medial pterygoid going underneath here. Lateral pterygoid, there's not much you can do, but it's really that medial pterygoid. And that's the one that really limits that opening. So that's why it's so important to work on. So trying to get in as far as you can on that lower section of the medial pterygoid, but then see you reach back there, and there you can get more of that belly. But that's behind the jaw. The jaw's been cut away here, the mandible, I should say. So that's why you're going just medial to that mandible. And be careful for gag reflexes. Just talk with your patient, say, hey, does this bother you? Do you have a really overactive gag reflex? Maybe just go to the area once, pull your hand out. How is that? No, I'm fine. Okay, how about here? Any gag reflex? Okay, good. Well, then you sit and work on it. It's like, no, it just really hurts. It's painful. This is a technique that can be used if somebody just really has a lot of OA going on in that joint, tons of clicking and popping, and it just constantly turns into kind of overuse issues. And you might need to just remodel the condyle, the disc and the soft tissue in that area. So with this, you can use a piece of surgical tubing and cut off a 1/2-inch piece. So it's like a circle. I'll demonstrate with my pen here. So then I'm going to put that in between my teeth here, and I'm going to follow the instructions. And at the very beginning, all I'm going to do is keep that there, and I'm going to try to just deviate away from the painful side. So if it's this right side, I'm trying to deviate to the left and come back. And I'm just letting that thing roll in between my teeth as I go back and forth. When that's no longer painful, so that's kind of that, we're restoring motion to that area, and we're helping increase that distance in the case of disc dysfunction. But when that's no longer painful, now we can start encouraging the muscles to be retrained. And by doing these exact motions here, we're actually helping encourage that actual tissue there to remodel. So then you just follow the instructions. So then it's going to be deviate over, bite down, unbite, and then deviate back. And then deviate over, bite down, deviate back, and then unbite. So once you kind of get that going down, then you'll do the best you can to work with protrusion, or that's bringing the jaw forward and back, and when that no longer bothers them, forward, bite, unbite, back. And then it's finally forward, bite, bring it back, and then unbite. And all you have to do is just kind of repeat that 6 times. So that would be during the day at work, every 2 hours. You go through that process, and initially you're just going back and forth 6 times, but in that kind of where it's only open about 1 centimeter position, and then it just progresses from there. So again, any questions on this, holler, and I can walk through any of this in person, or I guess on Zoom. The last thing we get to would be the Rokubado 6 exercises, and with this one, first thing we're doing is teaching them where their tongue is supposed to be. So you say, all right, let's put your tongue, I want you to make a clucking sound. So it's, okay? So I want you to do that again, but this time just keep your tongue where you start. So that position, that's where your tongue is supposed to be kept all during the day. So hold your tongue in that position, and I want you to breathe through your diaphragm. And you might have to teach breathing, because if they're constantly breathing up here and all this is tight, then they get that CMD part, and the TMJ dysfunction will never go away. But we can shoulders down and back, and actually that's coming in a little bit, but it's kind of like try to just breathe through your belly breathing, the diaphragmatic breathing, and keep your tongue in that position. But also, it's totally fine to just do that clucking sound 6 times as part of the activity. But the big goal here is to get them in that appropriate position. The next thing we do is put the tongue in that appropriate position, and now do controlled rotation, and they need to watch in the mirror. And let's make sure when you open your mouth, your teeth are staying in line with each other, and you're only doing rotation. And by them keeping their tongue there, it's really going to encourage just that rotation. So they might be looking in the mirror, and it's just opening and closing slowly and controlled 6 times. Again, helping to kind of re-educate. This is like the NMR activities of the TMJ dysfunction. The next one is the rhythmic stabilization. So now they are holding their tongue in that position, and now they're applying isometrics while keeping in that neutral position. The next thing we come to would be the upper cervical distraction. And with this one, this one is a little bit different than I normally teach it. The one I kind of skip to normally is the 5th one, which is essentially you hold your tongue in that good position, and then you go into that cervical retraction that we just went over. The final one we get to is then 6, where then shoulders down and back, you're promoting that retraction again while breathing with the diaphragm and keeping your tongue up where it belongs. So essentially, all it is you keep your tongue in that appropriate position, and you make sure you can open and close with rotation appropriately. You make sure you can hold isometrics of those muscles, and you make sure you have good overall cervicothoracic posture. And as long as you do all that, and you check that every 2 hours, that's going to help put your TMJ where it belongs. It's going to make sure the muscles are working appropriately there, and really just set a patient up so that all the hands-on work you do is essentially then what fixes them, because then all this positioning will just keep them better. Attached here would be surgical protocols. We're not going to get into the surgery and all of that, but technically speaking, some people can get surgery to that area at a certain point. So then here would be the protocol you'd follow with treatment. So spend a minute or two and just glance over some of those basic things and no big picture concepts there. So I'm sure I opened up a ton of can of worms here. I know there are tons of questions. Normally this is done over a 3-hour lecture lab. So please, if I forgot to bridge a gap somewhere, I didn't come back and show you a certain type of treatment, or you're just missing something on your clinical reasoning, please, again, write these things down so we have them for Friday and we'll go over them at that point. See you later.